guys see that?
Yep, that's perfect.
Okay. Good.
Yep.
All right, hi guys. For those of you that don't know me, my name is Jenna Cabrera. I'm a third-year physical therapy student at Bradley University in a little podunk town in Illinois. That is way less exciting than here. So I am.
Once you go last, you won't be
Oh,
able to,
yeah.
you won't be able to hear you on there.
You guys are actually, you can see my face. Darn it, now I can't be a superhero. I am going to talk to you guys today about public health considerations as an orthopedic outpatient physical therapist. So I think sometimes we feel a bit siloed, like, you know, unless you're specifically a public health PT, how can you be thinking about that and implementing it in your day-to-day practice? But the reality is we really need to be doing this, and we are doing a bit of a disservice to our patients if we're not at least thinking about the pelvic floor and public health, because it's a huge part of who we are and what we do day to day. And so I'm speaking about this from a place of having finished my level 1 course with Herman and Wallace for their public health. So I did that in the fall. I've been interested in public health for a while, so I'm really excited to share with you guys what I've learned, and hopefully you'll learn some stuff too. So how did I get here? So these pictures on the side here, I'm pretty active. I've been active my whole life, but what do all these pictures have in common? In every single one of these pictures, I had some incontinence issues occur. You can tell I wasn't very happy about it. It started when I was pretty young. I would say early 20s. I'm older than I look, guys. So when I was younger, this started occurring. I had never had any issues with this before. I've been a healthy individual my whole life. Very startled by it. Wasn't sure what to do about it. Didn't want to talk about it because there's this stigma around it, right? Like, I don't want to tell people I'm wetting my pants, right? I'm not a little kid. This is scary. What's going on? Just kind of ignored it, pushed it under the rug. It kept getting worse. It kept happening in the worst times too, right? A lot of these are in the middle of competition. So if you can imagine having a little puddle around you during competition is just not a fun thing to deal with. Also not really safe because you can slip in it. Been there. So that led me into wanting to understand more about what was going on with pelvic health. A few years later, I started to have really bad low back pain and tailbone pain. Could not figure it out. Went to doctor after doctor after doctor. Couldn't figure out what was going on. Finally, by chance, I ended up at a pelvic health PT clinic. And that's where we figured out it was all about my pelvic floor. I had been, since I was young, just a very strong athlete. I had a lot of muscle, but I also kept myself very tense, which meant muted, or I'm muted. Okay. You guys might not have been able to hear that first part then.
Click on your unmute.
Well, I think now I'm unmuted. Yeah. Okay. They might not have heard that first part. So, you know, short recap. I love pelvic health. I had some urinary incontinence growing up. That's why we're here now. Okay. So Kegels are something that can be absolutely necessary, but if you have a patient come to you telling you they're doing Kegels, you will want to talk to them a little bit about that, find out what that means to them, and find out who told them to be doing that, right? Because if the internet told them, that may not be what they need, right? So if a pelvic health PT told them, then great. I'm sure they instructed them on it. Let them Kegel away, right? Next thing we need to talk about is leakage after pregnancy is not normal. It's not normal before too, right? It's become this thing in our society where it's like, yeah, I go to the bathroom when I cough, when I laugh, but it's fine. That's just the way it is. I had a kid. This is one of the side effects, but that's not true. And that shouldn't be the case. So we need to destigmatize this idea of having incontinence issues and being able to talk about it and dig into why is this happening, what's going on, instead of people feeling like it's just something they have to live with. 'Cause nobody should have to live with that. And a healthy pelvic floor does not leak. And I think that's the thing to remember. So if someone's having leakage, something is not going right in there, and we can help them figure out a little bit of where that might be coming from. Another thing to really think about, and I'm a kind of a lighthouse for this, is incontinence isn't just an elderly population problem. And we are seeing more and more young athletes, especially, dealing with this problem. And it's kind of one of my passions because I don't think it's ever talked about. So they are silently dealing with these issues. It can be constipation, it can be incontinence, it can be just really painful periods, painful bowel movements, all of those things. They're not normal and they're happening in our younger population. And it's our job to be helping identify those things and getting them the help they need so that they're not in pain, because they're already dealing with so much as an athlete. And then if you're adding this component to it, this can create, depression, anxiety, other pain, and it's just not a good thing. So it's our job to help with that. Another thing I want you guys to think about, this may be something you've done growing up. I know I sure did. Don't go to the bathroom just because you might need to go later. Okay, this is actually not a good thing to do. We are training our bladder to be smaller and hold less, and that's not what we want. Our bladder is smart. It's built to signal and tell us when it's full. And so waiting for that, I don't want you so peeing your pants because you waited too long, but you can wait and try to follow that natural rhythm. It's called bladder retraining, and it's actually something you want to make sure if your client is talking about they're going to the bathroom constantly throughout the day, you may need to talk to them about that. Like, okay, is that because you actually feel like you have to, or you're just in the habit of it? Okay, because my dad was always really bad about, well, we might not see a bathroom again for 4 hours on the road, so you better go now. But if I don't have to go, I shouldn't go, right? So that's something to think about. And then one big thing I want to talk to you guys about, especially in today's world, pelvic health it's non-binary, right? It's for everyone. It's not just for individuals who are assigned female at birth. That says is only, it's supposed to say is not only. Everyone has a pelvic floor, surprise, you've all got it. And so we need to be thinking about it with every single patient that comes across our door. We need to try to make sure we're presenting ourselves inclusively, right? So that they don't think they can't talk about it, or they feel shame to talk about it, because we all have it. So it's like belly buttons. We've all got it. Don't always know what it does, but it's there, right? So what does our pelvic floor do? What is this mysterious pelvic floor we speak of? Think of the 5 S's here. So it supports us, keeps our pelvis and organs in place, and then also increases our intra-abdominal pressure, which we're going to talk about a lot today. You guys have heard about the soda can theory. It's like we're a soda can, right? So the bottom of that soda can is my pelvic floor. Super important. It's also sphincteric, so it contracts and relaxes, allows us to have bowel movements, go to the bathroom, also holds those things in when we need it to. Has a really important sexual function. Again, I think there's some stigma here. In fact, when the first research was done on pelvic health and Kegels, the women came back and reported having better orgasms, but the researchers didn't want to talk about that. So they didn't. But there was a huge thing at play there, right? So it has a really important sexual function in achieving, sustaining erections, orgasms. And let's be honest, that's an important part of life. And for a lot of people, that can be debilitating. And if it's something we can help with, heck, why wouldn't we help with that, right? That's a great thing to add to your resume. Stability. So it's going to help keep everything in place. It's really important for our abdominal muscles, our hip, our back muscles. All of those things work together, connect into this big old pelvis to keep us stable and in place, right? Without this, we would just be a mess. The other thing to think about, though, is if you have too much stability, so like in my case, you're too tight, you're too strong, that can actually cause a lot of pain as well, can cause compression and restriction through that area. So we're not just looking at people who are weak down there. We need to look at people who might be too strong down there as well, because that can be just as much of a problem. And then the last thing it does, it's called a sump pump. So basically, it allows that blood and lymph to pump in and out of the pelvis, keep things moving the way it should. And then one thing I don't want you guys to forget about that's going to be really important for us especially is posture and breathing. The pelvic floor is like the king of this, or the queen. So it's really important for these two functions. So I know you guys know it, but just a fun quick anatomy review for you. This is our pelvis, right? So we've got a lot of different things that play into our pelvis here. So up top, we've got those iliums, right? And then they're connecting in. We've got our pubis coming down here. We've got that ischium, and then that pubic symphysis that there's much debate about how much movement occurs in this area. and that's a talk for another day. But it does matter, right? All of these things, there's a lot of connection points here. We turn it around, we've got our coccyx and sacrum, which is where some of my issues were coming from. And again, there's talk about how much movement occurs here. I don't want to get into the nitty gritty of that, but I want you guys to be aware of all the things that are going on in here, right? So we've got the spine connecting in here. We've got our hips connecting in here. And then we have all these muscles in here that's supporting all of that, which is a really big job for it to be doing. If you think about it, because without it, literally things are going to be falling out of us, which actually can happen. So just a little review for you there. I'm just thinking about the fact that this pelvic girdle, it also, if you guys have learned about form and forced closure, right, remembering that that bony structure helps increase our stiffness and stability. And then all the muscles, ligaments, fascia that connect into it also provide that stiffness and stability we need. So it's just really important, which is why it makes me sad that people don't talk about it. This is not something we're going to deep dive into, but I want you guys to be aware. This right here, this is called the pelvic clock. So you could externally follow this clock and find all these different muscles. I do not expect you to be palpating these things, right? Because that's going to be probably more of a pelvic floor therapist job. But just keeping in mind, like, look how much is going on down here. Any other joint in the body with this many muscles, we'd certainly be paying attention to it, right? Oh, I'm out of them. Sorry, I got so excited. So all of these muscles, they matter. They all have different functions. We can palpate these all externally. But again, probably you're not going to be doing it in your practice, but I want you thinking about it, because if they're noting pain in those areas, it's very likely one of those muscles could be contributing to that. So again, you're probably not going to be deep diving, but good to remember how much is happening down there. For you guys, this is going to be key right here. So these are the muscles you need to be thinking about in relation to the pelvic floor. So we've got that pesky piriformis muscle, right? We all know that's a fun one to try to get to. Helps with that hip extension and abduction. When your patient comes in, they may be talking to you about having buttock pain, low back pain, back of the thigh pain, even into the calf and foot, some sciatica-like symptoms, right? So piriformis, I think in our minds, we think hip, but it ties into the pelvic floor. It attaches to the pelvis. So very likely you could be dealing with a little bit of pelvic floor stuff here. So I don't want you to forget about that when people are presenting with that. I'm going to show you guys too how we can palpate some of these externally in maybe a deeper way than you've currently been doing. So obturator internus is the next one I want you guys to think about. Does that external rotation and a lot of stabilization through the hip. For this, you're often going to hear them talking about pain right in those genital structures, as well as the back of the same side thigh. Okay, so they may have it, oh, I feel it a lot in my groin, they might say, right? And then in that thigh as well. That should kind of turn on a light for you, because we don't often see those two areas coming in together. So it could be a really good sign that that obturator internus is at play, which again, that's a tough one. We probably don't palpate that often, but I have a good way I'm going to show you guys of how we can palpate it and find out if it's tying into that pain. And then those adductors, right? And we all know the adductors do a lot of adduction of the hip, but also that external rotation and flexion of the hip. This one, you're going to see that groin pain, but you can also see it in the knee, the shin, and in the same side front of the thigh. So this one, I want you to be thinking about. We think adductor, but I don't think we think, hey, those adductors go really high up and attach into my pelvis. Maybe that's the source of the pain. And often, if people have adductor pain up there, they also have some pelvic floor stuff going on, because they attach so closely together and they function together. So this one especially is one I want you to be thinking about when we're thinking pelvic floor. So one thing else I want to talk to you guys about is just pelvic positioning. So we know when we're looking at our patient and we're analyzing their posture, we're thinking about anterior, posterior pelvic tilt, right? But for us, I think we're thinking about that more with terms of low back pain in the spine, and how is that impacting the shortness of the hamstrings or the hips, right? I bet you're not currently thinking about it in terms of pelvic floor. But here's the interesting thing. How someone has their pelvic floor can help determine how well they can have a bowel or bladder movement. Okay, so when they're in that anterior pelvic tilt and we've got that anal triangle, urogenital triangle more on slack, they are going to be able to urinate better. So if you have a patient telling you they're having some incontinence issues, it is well within your scope to say, hey, have you played around with just tilting your pelvis when you're on the toilet? That's literally sometimes all it takes. Super quick fix that you can implement, but this can also tell you maybe there's some more pelvic floor stuff going on and you want to refer them out. Right, but this is a great place to start. Basically, what I want you guys to realize is you are not helpless when it comes to pelvic floor. And you can absolutely be interacting with your patients on this stuff and give them a few quick things. Maybe this is all it takes, right? And then they're going to love you and think you're a magician, which is always our favorite thing, right? And then I want you to think about the opposite happening, right? If you have that posterior pelvic tilt, that's going to allow those bowel movements to come through better. This is why you guys have heard of the squatty potty, right? This is why it works, because it's putting us in that posterior pelvic tilt. Those anal triangle muscles are relaxed and can allow that bowel to flow freely. So again, just something to mention to your patient. Hey, have you tried the squatty potty? Have you tried lifting your legs? They might look at you funny, but they'll try it once and they'll be like, okay, I get it. I get it. If you haven't tried a squatty potty, I actually encourage you to, because it's going to allow you to feel what's going on there. And honestly, I think they're pretty cool. So just an easy thing you guys can start implementing right away. Now, to Kegel or not to Kegel? That is the question, right? The big question. So here's the thing. If you aren't doing an internal exam, you're not going to be able to know for sure if this is what they need. So if they've been instructed, like I said earlier, by a pelvic health PT to Kegel, you can add this into your treatment because they've already been taught what a proper Kegel feels like. They know it. So you can tell them when you're turning on your transverse abdominis muscles, I want you to also perform that Kegel, right? Because those should be happening together. So we can start to teach them how to coordinate those structures together and get a little bit more out of their treatment. Now, if they haven't been told to Kegel by a professional, like I said, I would be telling them, if that's something you think you need, why don't you get in with a pelvic health PT and find out what's really going on? Because they might find out that the opposite is true and they need to actually be relaxing their pelvic floor more. That was the case with me. I was Kegeling till the cows came home and all it was doing was making everything worse for me, right? Because that's not what I needed. So I think it's our job to have enough understanding to advocate for them and say, hey, actually, let's get you in with someone who can tell you whether Kegel is really the right move for you. Okay. Same thing too, if they're talking to you about like weighted eggs or any of that sort of stuff, if they haven't been told to do that by a professional, I'd be advising them to wait and find out what's really going on because it could do more harm than good. So something I want you guys to keep in mind and something you can absolutely be implementing. I want you to feel empowered. You can tell them, yeah, do your Kegel. You know what to do. Let's turn that on right now. Okay, now let's turn that off and start working with them on that stuff. All right. Really fun fact you may not know. Your ankles even impact your pelvic floor. So how your ankle is moving is going to impact the way your pelvic floor is turning on and off. Research has recently shown if we're in a plantar fixed position, we're getting less activity through the pelvic floor. This is why we don't love our ladies wearing heels, especially chronically, right? That is why it's actually been tied to having incontinence issues. When you're in that chronic state of plantar flexion, it's keeping that pelvic floor on slack and it can create some issues there. So we have found that dorsiflexion position, about 15 degrees, is perfect for helping turn on the pelvic floor. So another thing you guys can be doing when you're doing TRA contractions and you're telling them to do their Kegels, if that's what they're supposed to do, have them bring that dorsiflexion in too. They might be able to turn that on better and feel a little bit more of a connection. This is also why we like to get people in standing when we can, when doing abdominal stuff and pelvic floor things, because they're already in that natural dorsiflexion, right? So they're already going to be engaging it better. So you can play around with this. Just one more way you guys can make a difference. And also I think that's kind of cool, right? Who knew the ankles could affect something way up here? Just a really good reminder that everything is connected, right? It's never as simple as it seems. All right, so some fun tests that you guys can implement and you might already be doing, but maybe not for the purposes of pelvic floor. So that active single leg raise, right? In terms of pelvic floor, we can use this to assess how good our patient is at transferring their load from one side of the pelvis to the other. So I want you to just have them raise their leg and watch what's happening. Are they rotating through their pelvis to get that leg up? Do you see a belly bulge, right? Especially if you have a pregnant patient, this is something we really want to be aware of. Are we seeing that coning effect where those abdominals are not doing a good job of supporting them? One way you can kind of retest this, if you notice they are getting rotation, is add some compression to the abdominal area, have them do it again, see if that helps. What does that tell us? Oh, they need more stability through the abdominal area, right? So this is a great test you guys can absolutely and should be implementing with your patients. And then also you can try breathing cues with them. I'm going to talk a little bit more about this in a little bit, but breathing is really important when it comes to pelvic floor. And it might just be that they're holding their breath, right? Or engaging their diaphragm incorrectly, and that's causing the lack of stability through that area. So just something to think about next time you do that good old single leg raise. All right, so
I want you guys to grab a partner. You guys at home probably can't grab a partner, but we're gonna palpate the obturator internus. Come on, guys, get up, get up, get up, get up. Let's do this. So you're gonna grab a partner. One of you is gonna be in side lying position. So pick who's gonna be the patient first. We are gonna get into that obturator internus. Everybody get a partner, get in that side lying position. So we are going to be palpating that bottom leg. So that top leg is up and over. Ideally, you'd have a pillow, but for you guys today, you can just kind of bend that leg in front. You are going to be taking your hand and trying to sink in to the, find the ischial tuberosity, and then you're going medial to it. The hand is angling down toward that opposite greater trochanter. So you're going to have this sort of positioning right there in the middle of the thigh. I don't want to leave the screen. You're palpating the bottom leg. It's going to be on the top of the leg though. So we're near kind of where the adductor is, but back a little bit. So bottom leg. Yeah, so you're heading down. So if you're at home, we're working on trying to figure out how to set this up and how to palpate up a little bit higher. So you're going to be starting honestly. Use your hands. I want you guys to be gentle. Make sure you have like a flat hand here. Just coming right down. All right. Now have your patient push their bottom knee down into the floor, and you should feel that muscle turn on. Yeah. If you feel that you're in the right place, if you don't, move around a little bit. And then you guys can switch partners. So you should feel it turning on. Yeah. And that's your obturator internus. Switch partners and try it again. If you're not finding it, play around moving the hand a little more medial or lateral. It'll be higher. Yeah, like almost in the crease. Yep. Yeah, and then head at an angle more down toward that. And then try to push into the floor. And you should feel that baby turn on. Obturator internus. So that's a great one that you probably didn't even know you could palpate. Yeah, exactly. Yeah. Yeah. So just a fun little tidbit for you guys there. So this is just a reminder that sometimes we aren't palpating deep enough, right? Sometimes I don't think we're palpating good enough. I think we get lazy and we just palpate through the muscle belly, but we don't think about where it attaches and what's going on there. And this could be really important because if you guys do this and you have them kick into the floor and they go, man, that reproduces my pain, ding, 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 right? We know that obturator internus is involved. And you can absolutely do manual in this area with consent, making sure it feels comfortable for them. But I bet your bottom dollar, if this is really bothering them, they're not going to care if you get in that area. So that might be a fun one you didn't know. I was pretty excited when I realized that because I always thought we can't get to that muscle. I can't feel what's going on there, but it turns out we can. So another test that you can do is that single leg stance. I guarantee you guys are doing single leg stance right now, but again, maybe not thinking about the pelvis and how they're using or not using their abdominals in this stance. So when you're doing this, I want you to look at obviously balance, right? Because that's going to be a big one. But what postural strategies are they using to maintain a single leg stance? As outpatient orthopedic PTs, we think about the glute med a lot. But are we thinking about abdominals? Are we thinking about breathing, right? So what I want you to look at is, do you see them really turning on their abdominals to hold themselves in this position? Do you see them holding their breath to provide stability? That could be key, that pelvic floor is not providing the normal stability it would in this position. And we might need to be talking about that a little bit more. Okay, so just something to think about when you're doing that single leg stance. All right, I know you guys are just on the ground, but you're gonna get back on the ground. But next we're gonna do the adductors. Now I'm sure you have palpated the adductors, but I bet you haven't palpated them at the insertion of the ischiopubis ramus. So I want us to find that ischiopubic ramus area and palpate right into those adductors. And I'm gonna show you how we can turn that one on and feel it too. So get back with your partner. This is an active thing, guys. Gotta keep you moving.
Where did you say the obturator internus refers to?
No, you were right. Gosh, now I gotta remember. No, genital structures in same thigh.
So like patient with back pain in the genital or back to the thigh.
Could absolutely be that obturator. Yeah, which I bet we see that now that you hear it, you're probably going to start seeing it more, right? Because it's like when you get a new car and you see your car everywhere. So, okay. So for the adductor, you can do this in side lying or hook lying, whatever's comfortable for your patient. I will tell you, I think side lying is better to truly turn it on. Man, I got a rough crowd. The dog doesn't like my talk. All right. So you're going to follow your fingers along the adductors until you get up to that top of that ischiopubic ramus where that insertion point is at. Okay, so it should be right kind of along in here if they're laying down. Oops, I'm backwards. There we go. Right through here. So you're doing that bottom leg again. You're crawling your fingers up and then it should be all along through here where you're feeling those adductors. What you can do is have them perform resisted adduction into your hand to confirm that's where you're at. So follow those fingers up. Yep. And then you're going to have them push into your hand. And it's going to be higher than you expect. It's all the way up in there, right? You should be feeling the pelvis right up there. And then you can have them push their leg into your hand and that'll confirm it. You guys feeling it? If you're not, let me know, I can help. Yep, they could just do an adduction raise and you should feel that puppy fire up. You might be a little far back, Manny. Yeah, are you getting it? So the thing with this is, remember the adductors, we have a lot of them. So you could be feeling multiple insertions here. This is going to help you differentiate which adductor might be creating that pain. Yeah. Oh, yeah, I'll wait till we calm down. And then So key points here, guys, is we have multiple adductors, right? And it's often hard, especially when we get down lower in the leg, you just think, oh, it's the adductor, right? But this can help you determine which adductor, and is it more up at that insertion point versus down at the muscle belly. I bet you a lot of times they're getting referred pain down, but the source of their pain is up higher. And this will be pretty tender if this is what's going on there. You see this a lot with groin strains too. So keep that in mind. It's probably coming from higher up in that structure. And another area we can absolutely provide some soft tissue to, some manual, get them feeling better. So you guys didn't know you were going to get so close today, did you? Okay, so next thing I want to talk about is pressure and breathing. I love this meme. I think it's hilarious. It's a good reminder that pressure is not always a bad thing, right? Pressure creates diamonds. Pressure creates new ideas. So we like pressure. But we need to be thinking about pressure in terms of internal and external factors. So when we're doing a really strenuous activity, me as a weightlifter, right? When I'm throwing multiple hundreds of pounds over my head, that pelvic floor has to be turning on and keeping that pressure where it needs to be within my abdominal cavity. If I can't do that correctly, we're going to have injury. We're going to have pain, right? It also really is important to remember that our breathing and pressure, they come together. So if I'm holding my breath, that creates the most intra-abdominal pressure of anything I can do throughout my day is breath holding. That Valsalva maneuver creates the most pressure possible. So I need to make sure we don't want our patients holding their breath, but this is why, right? They're creating insane amounts of pressure through that abdominal area and they can likely get injured. Think about the fact that the diaphragm and the pelvic floor work together. They're a synergistic system. So they relax and contract as one, or they should. But I bet you a lot of your patients are not doing that. Because how often do you tell them to do an ab thing and they hold their breath? And they're like, well, I can't breathe and do that at the same time. Well, you should be able to. So we need to coach them on that. That's absolutely within our scope to teach them how do you engage your abdominals, but also breathe through it. So that's one easy place you guys can start. And if you're seeing dysfunctions in their breathing patterns, it's very likely the pelvic floor is getting involved. And research shows this is a large amount of our low back pain patients. So we see tons of low back pain. We need to be thinking pelvic floor right away. We need to be thinking breathing. And then I think if you start to look at those things, you're really going to see the pieces of the puzzle come together a little bit. Another thing too is if you have a low back patient, absolutely be asking them about incontinence, because it's possible and fairly likely they're having some and they just haven't talked about it. Don't be afraid to ask these questions. Don't be afraid to talk about bathroom habits, right? Because they're really important. So pop quiz, what do your pelvic floor muscles do when you cough? I want you to cough right now and tell me what happens down in your pelvic floor. Big cough. What happens? Who had felt it contract, pull up? Who felt it relax down? Who felt nothing at all? Who has no idea? Okay. That's pretty common. Okay, so a lot of times we don't pay attention to our pelvic floor normally, so we don't actually know what it's doing. So this is just a good reminder to be paying attention to that pelvic floor. But think about it, right? As that diaphragm comes up, we breathe out, or sorry, as we breathe in and that diaphragm comes up, the pelvic floor should be coming down. So we're creating more space for that area. And then as we breathe out, it should come up. So they kind of work synergistically to increase the space and decrease the space. So that maintains the proper pressure. It's that soda can theory once again. So that's a fun thing to do with your patients. Have them cough, find out what's going on, see what's happening down there. You'll be surprised that they're not going to know, or it's going to be the opposite of what it should be. I was really bad about this. I was doing the exact opposite. This is why people, they lose some pee when they cough, because their pelvic floor is doing the opposite of what it should be doing. So which activity do you guys think has the highest inter-abdominal pressure? Do you think it's a full sit-up, coughing like we just did, jumping, or lifting and carrying 18.2 kilograms, which is like 35 pounds? Who thinks sit-ups? Who thinks coughing? Who thinks jumping? And who thinks lifting and carrying? It is coughing. So believe it or not, just when we're looking at just total intra-abdominal pressure, that cough is creating more pressure through there than any of those other activities. This is why I have a little bit of beef when we talk about not loading for back pain, right? Because granted, they need to do it well and there's other structures at play, but as far as we're concerned about pressure through the body, they're getting more pressure when they cough than when they go and lift something or when they run. So we need to be teaching them to lift and provide proper pressure. So context is really important here though, because I'm going to give you a caveat. When you're looking at what we call area under the curve or the amplitude and duration of the pressure, we're going to see something different. Lifting tasks require sustained elevated pressure, right? Whereas a cough does not. A cough is a quick, lots of pressure back down. But when we lift, I have to hold that pressure for a longer time. So when you look at that, lifting and sit-ups are way higher overall. Right? So still important to remember, if you hear someone say, well, cough is more pressure, I was kind of leading into something there, because ultimately we have to look at the context of it. And overall, they need to still be able to regulate that pressure longer, which comes down to endurance. And people don't always have great endurance of their pelvic floor. So this is a little just graph for you guys to see the big difference there. You can see coughing, while it's higher overall, it's a much shorter time frame there. So modulating force production is the next thing I want you guys to think about, okay? We need to have pressure all the time, but the amount of pressure we need is different depending on the activity we're doing, right? If I'm going to pick up my kid versus pick up a box of tissue, that's a very different amount of pressure required. So what I don't think we talk enough about or do enough is teaching them how to change the amount of pressure they're applying depending on what they're going to be doing, right? If I just told you to go lift an unknown object, you would not know exactly how to prepare for that lift. Could end up throwing your back out, right? Or creating issues because you didn't create the right amount of intra-abdominal pressure. This is all about neuromuscular control, right? So I want you guys to remember when you're doing any sort of lifting with your patient to remind them, okay, we're about to lift this 5-pound kettlebell. Let's think about how much pressure you have through your abdominal cavity as you lift this versus when I go over here and I lift this 20-pound item. Right? Versus when I'm walking up the stairs. I want you to have them start thinking about these things, because you're going to be teaching that pelvic floor when to turn on more versus less. Right? Our pelvic floor is always running in the background. It's like a computer. It's always humming. It's always on. If it wasn't, you'd literally have organs falling out. But we need to not have it always up or always down. We need to teach it to be able to go in and out as needed. So this is something that I think is pretty cool that I think we can absolutely implement here in our clinics. Teach them how to modulate their force. So thinking too about those local and global muscles, right? We often think pelvic floor, transverse abdominis, multifidus, but also we need to think about those internal, external obliques, the rectus abdominis, erector spinae, they all play a part in that force production. So don't tell me that you don't do pelvic floor, so you don't need to worry about this, because there's all those other muscles that are creating that force production as well. And they can modulate those just the same way. So teaching them how to tailor that to their activity is going to be really, really helpful. Next thing I want to talk about is breathing. So with breathing, you should always be thinking about this with your patient. When you're first just looking at their posture, you're looking at their breathing, right? We learned that in PT school. So I want you to look for symmetry, side to side. I want you to look for the rib cage. Is it moving? And is it moving at all? Is it moving too much? I want you to look to see, are they breathing through their stomach? Are they breathing through their chest? What do we not want to see? We don't want to see vertical rib cage motion, right? It should be coming out horizontally. And you can do this by putting your hand on the patient's rib cage, having them breathe into it, feel that expansion. We want to see if they're breathing through one side more than the other. This can be creating all sort of like issues throughout the entire body, right? If I'm breathing more on one side, I can have shoulder pain, neck pain, hip pain, all sorts of issues. If they're using a ton of accessory muscles, this is a key for us, that they don't know how to breathe correctly. So they're absolutely not engaging their pelvic floor correctly. They're not going to have good intra-abdominal pressure. And then also look to see if they're breathing a ton through their mouth or holding their breath. Just look at their breathing. Just try this with your next patient and see what's happening. You might be surprised at what you find. So what can you do about that? So first things first, just teach them how to relax. In today's society, I don't think we're very good at relaxing. So teach them to just tune into their breathing. Have them lay on their back, put one hand on their chest, one on their belly, and just say, breathe. And see what they find. Are they seeing their hand rise to their chest, or is it rising to their belly? Maybe it's doing a little bit of both. This is just a great way for them to start tuning into their breathing, calm themselves down, and relax everything. From there, you can start to teach them about relaxing that pelvic floor with it, right? And then bringing that pelvic floor into contraction and just kind of talk them through that movement. One of my favorite exercises to do with this sort of thing is called the balloon blowing exercise. This is an exercise performed in 90-90. You've got the feet up on the wall. You can put a ball between the knees, you don't have to. And then they've got a balloon, and you're just teaching them to breathe into that balloon and then breathe out. Like you're just having them breathe. Like, you know, when you were taught for anxiety to breathe into a brown paper bag, it's the same idea. We're trying to regulate that breathing. Not only is this going to retrain them for proper breathing, but it's actually been shown to have a really good neurological response in calming the system down, right? We spend too much of our day in flight or fight and not enough of our day in rest or digest. And research is showing that that fight or flight is creating more injuries, it's creating more pain. So let's get our patients back down to that rest and digest place and see if that alone might change some of their pain. So just something fun to think about and maybe give a try. I won't make you guys try that one today. So big takeaways, because I know I talked about a lot. Check posture and positioning. If your patient is talking about any sort of pelvic pain, back pain, look at the pelvis, right? That's where it all starts. Look at their gait, look at their ankles. Don't forget about those ankles. Look at their breathing and talk about their ability to contract and relax the pelvic floor. See if they even know what that means, right? Start there. Remember that pelvic health is for everyone, and it plays a huge role in our posture, our stability, our breathing. That means it impacts what we do in orthopedics, right? There's no way around it. That's so much of what we do. Remember that you can palpate those surrounding muscles, and you can palpate them accurately, right? You now know you can palpate the obturator internus. You now know you can palpate that adductor right at that insertion site and maybe get a better idea of what's going on. So don't be afraid to play around with that. Think about breathing. You may need to retrain your patient on how to breathe. And that seems really basic, but then that's gonna make everything else you do easier, because you're gonna know they're using their diaphragm correctly, they're creating good pressure. Remember to modulate force production. Talk to your patient about how much force do you feel in yourself apply right now as we go to lift this weight? How much force did you feel when you went to lift your child up out of the crib and you got that back pain, right? Let's dig into that a little bit more. And then one of the most important, if you feel like it's really a pelvic floor issue or they need to get some more internal work done, please, please, please refer them to your local pelvic health PT, because they can dig into that stuff a whole lot more, give them some good stuff to do, and can also give you things that you can be doing. So those are my big takeaways. I hope you guys learned something. Lots of references for you here, and any questions? Okay, yay. Do I stop that on here? Okay.